Moghaddas. He's coming from Tehran, Iran. He's our next speaker, and he's going to present the paper about efficiency of connective tissue and ABBM with and without PRP in treatment of intrabony defects.
Thank you, Mr. Chairman. Good evening, ladies and gentlemen. The topic I want to talk about today, as Mr. Chairman presented, is the efficacy of connective tissue and ABBM with and without PRP in treatment of intrabony defects. Guided tissue regeneration, as we know, aims to reconstruct periodontal tissues that have been lost due to trauma, periodontal disease, or any other causes. And so many different treatment modalities have been proposed for this aim. Over the past years, using connective tissue as autogenous barrier have been mentioned and considered. So now I'm going to briefly take a look at the review of the literature about this concept, and then I'll go on. In 2010, Fournier said that the gingival connective tissue has progenitor mesenchymal cells, which are important in regeneration of the tissue. Mitron also stated that these mesenchymal progenitor cells are able to be osteogenic, which is the point that we want in regeneration of the tissue and regeneration of the bone. And also Tomar showed that in 2010 that these mesenchymal progenitor cells in the gingival connective tissue are available in a higher level than what we can find in bone marrow cells, which is also important to notice. We have randomized clinical trial on this topic. By Wang and Camargo, they showed periosteal connective tissue have better results than open flap debridement. Moghaddas and Karimi also showed that the periosteal pedicle graft can be a better option than open flap debridement. The same result were confirmed by a study by Jamal 2008. Also, they showed the same result and confirmed the data that I presented. Moghaddas and Sultani showed comparable results of collagen and connective tissue as a membrane. In 2010, Paul Antoni also again showed the same results. Connective tissue can be comparable to collagen membrane. Also, we have in 2012 Journal of Periodontology, Feminella did a case report, a histological study in human, and also showed the capability of connective tissue to act as a barrier. So these are the important research that I want to present first. One of the other factors that have been used in regeneration of the tissue is platelet-rich plasma, using polypeptide growth factors. Not only they improve wound healing, but also they increase bone deposition rate. They increases the bone volume, and also they have androgenetic, they have proliferative and differentiative effect on the osteoblast, which is all important in regeneration of the tissue. We have important literature also here. The study by McCavick, by Dury, two separate studies in 2007, which I'm happy is here today. They showed that the combination therapy using membrane bone graft with and without PRP doesn't make any differences, whether it's going to be used resorbable membranes or non-resorbable membranes. On the other hand, we have literature by Camargo and Hanna. They showed that the combination therapy of using GTR, anorganic bovine or any other kind of feeders, and PRP shows better result than using membranes alone, or the combination with PRP shows better result than the bone graft alone. And also we have this study by Camargo that showed that the membrane alone can be comparable to bone material with PRP. This says that PRP has something to offer, but we need to know how and when. So, till now, no study has been conducted to compare connective tissue with PRP and without PRP, so we did design this study to see if there is any differences. Our study was a single-blind randomized clinical trial with range evaluation, and it was a split-month design to eliminate the confounding factors. Our study population, 15 patients with a pair of 2 to 3 wall intrabony defects, were enrolled in our study. Our sampling method was a convenience form, and all the patients should be systematically healthy under no medication with generalized chronic periodontitis with at least 5 mm proben pocket depth after the phase 1 treatment, with at least 3 mm clinical attachment loss and 3 mm intrabony content. And these were the two groups that we evaluated: connective tissue and anorganic bovine bone mineral, which we used BIOS with PRP, and in the control group without PRP. Informed consent were signed by all the patients. The aim of the study was explained to all of them. A thorough prophylaxis was done for every other patient, and also if they needed any periodontal surgical procedures, they were undergone the surgical procedure first, and at the last part, in a healthy environment, we did the GTR. These are the parameters that we evaluated in this study. Before reflecting the flap, clinical attachment level 2D stent, one of the parameters that we evaluated, gingival margin position 2D stent, and probing pocket depth from the stent. After reflecting the flap, these were the parameters. Defect depth 2D stent, CEJ 2D stent, crystal bone 2D stent, and also the depth of the defect itself. And our surgical protocol. In the control group, after doing the measurements, reflecting the flap, degranulating the area, root planing the root surface of the adjacent tubes to the defect, applying our bone material, a little bit overfilling, harvesting connective tissue graft with a thickness at most 1.5 millimeters. And this is how we trim the connective tissue and put it in the area on a safe bone margins and without any tension. And we used horizontal cross-mattress suture to fix and secure the connective tissue in the area of the defect. In the case group, the protocol were the same, and only we add PRP to our bone material according to company instructions. We prepared the PRP, I'm not going to go there now. And the same protocol was done in the group, only applying PRP and mix it with bone material. All the patient went through monthly cleansing, professional cleansing to 6 months, and we did the reentry evaluation at 6 months according to reentry. This is one of the results in our case group, the upper row, the before, and this is the after. And in our control group, again, before and the after results, and some of other results in some of our other cases. And some radiographic showings that the regeneration can happen in conjunction with connective tissue and bone material. Our statistical significance was defined as alpha 0.05, and also the power of the study was 0.80, giving more than 1 millimeter differences as a significance one. We compared the results between the groups with independent t-test, and we compared the results in each group to the baseline with students per t-test. And our results. Mean reduction of probing pocket depth of 2.8 to 3 millimeters were achieved in both groups. Clinical attachment level gain of 2.5 to 2.7 millimeters, mean. Gingival recession or gingival marginal position difference is only 0.2 millimeter in both groups. It was not a really big deal. Crystal position of the bone, 0.07 millimeter gain, mean in both groups. Bone field of 2.6 to 2.7 millimeters were achieved in both groups, and the defect resolution of 3.6 millimeters of mean. The differences between the groups didn't achieve any significance, but the differences in each group comparing to the baseline was significant. So both treatment modalities were important and were worked in this field. So if you take a look back at the literature, the studies by VIENNA, by Okada, by Corona, but all the people that I put some of the important one here shows that the PRP with any kind of bone material shows better results than bone materials alone. But if you come to other studies, by Lekovic, by Stavropoulos, by Camargo, you see, as I presented earlier today, combination therapy of GTR, bone material of any kind, with PRP shows better results than membrane alone. Also, GTR with using a material of any kind shows similar results to using membrane alone. And using bone material with PRP, similar result to GTR. It says that PRP has something to offer. But if you take a look at the other studies, by Dury, by Camargo, by Hostel, they show that the combination of using membrane, bone materials, only the differences, which is PRP, doesn't make any differences. So it's been stated in these studies that maybe the effect of the PRP can be masked in using membrane. We achieved similar results in using connective tissue as a barrier in our study, and also in different... Yes, it's all, yes. And other studies that use connective tissue. So, and the same meta-analysis and systematic review of Massimo Del Fabro also confirmed the same result that I presented to you. So my conclusion in this study is this: both treatment modalities were effective in treatment of intrabony defects. PRP didn't have any additive effect in improving the clinical parameters that we evaluated, and also connective tissue could have acted as a good alternative membrane. At last, but certainly not least, I want to thank Europerio7 organization for such a perfect congress. My honor to be part of it, as always. And I want to thank each and every one of you for your patience and your attention. And if there's any question, probably so glad to answer. Thank you.
Thank you very much for the presentation. Are there any comments or questions? Yes, please.
Thank you very much for this excellent presentation. Actually, it was like a pleasure to listen to you.
Thank you.